To Unit 8, everything we've built, probability, testing, disease measurement, causation, study design, outbreak investigation, surveillance, has been in service of one ultimate goal, making better decisions. This unit is explicitly about that. Clinical medicine, population health management, and veterinary public health all require making consequential decisions under uncertainty, with incomplete information, time pressure, and competing values. The tools in this unit provide a structured framework for doing that more rigorously, more transparently, and more defensibly than gut instinct alone allows. In this talk, we'll cover four interconnected concepts: decision tree analysis, which structures choices and their consequences; cost-benefit and cost-effectiveness analysis, which quantify the economic trade-offs; risk-benefit assessment, which weighs consequences, probabilities, feasibility, and acceptability; and utility analysis, which incorporates client values and preferences. These tools are used by individual practitioners making treatment decisions, by herd health veterinarians evaluating management programs, and by policymakers designing national disease control programs. Before we build the analytical tools, let's acknowledge why clinical and population health decision-making is genuinely hard, not because clinicians lack knowledge, but because the structure of the problem is inherently complex. Every decision involves at least four sources of uncertainty that operate simultaneously. Diagnostic uncertainty: we rarely know with certainty what disease we're dealing with. We have a probability distribution over a differential list shaped by our pretest probability and test results. Therapeutic uncertainty: even with a correct diagnosis, treatment response is probabilistic. Some animals respond, others don't, and we usually don't know in advance which category our patient falls into. Outcome uncertainty: even successful treatment doesn't guarantee the outcome the client wants. There may be complications, recurrence, or sequelae. And value uncertainty: different clients prioritize different outcomes. One owner may prioritize survival at any cost. Another may prioritize quality of life. Another may prioritize economic return. Structured decision analysis doesn't eliminate any of these uncertainties. It makes them explicit, quantifiable, and manageable. By forcing you to state your assumptions about probabilities and values, it prevents the hidden assumptions that drive gut instinct decisions from distorting the process. By systematically comparing options, it prevents anchoring on the first plausible choice. And by identifying which variables most influence the decision through sensitivity analysis, it focuses your attention on the uncertainties that actually matter most for this specific choice. Decision tree is a graphical model that maps out the choices available, the possible consequences of each choice, the probabilities of each consequence, and the values of each outcome. It's a disciplined way of thinking through what would happen if you chose each option before you make the choice. The three types of nodes are the vocabulary of decision trees. Decision nodes, drawn as squares, are points where you make a choice. You control these. Chance nodes, drawn as circles, are points where the outcome is determined by probability, not your choice. Nature controls these. Terminal nodes, drawn as triangles, are the final outcomes, each with an assigned value. Probabilities on branches from chance nodes must sum to 1 because something will happen, and together the branches cover all possibilities. Terminal node values can be expressed in any units that capture what matters: monetary values, revenue, cost, profit; utilities, patient well-being, quality of life, or whatever metric is appropriate for the decision. The foldback method calculates expected value by working from right to left through the tree. At each chance node, the expected value is the sum of each branch's probability multiplied by its outcome value. At each decision node, you choose the branch with the best expected value. The result is the optimal decision given the probabilities and values you've assigned. In our example, empirical treatment has an expected value of positive $500. Whether this is better or worse than the alternative, testing first, depends on the expected value of that branch. If testing costs $150 and correctly identifies the diagnosis in 95% of cases, leading to either treatment with recovery or appropriate switching of therapy, you'd calculate that branch's expected value and compare. The tree makes the comparison explicit and auditable. Let's work through a concrete clinical example. A 6-year-old cat presents with weight loss and polyuria polydipsia. Your two leading differentials are hyperthyroidism at 60% pretest probability and diabetes mellitus at 40%. You have two options: treat empirically for hyperthyroidism with methimazole, or test first with a T4 glucose and urinalysis panel costing $180. Option A, empirical treatment. If your clinical impression is correct and the cat is hyperthyroid, probability 60%, methimazole works. The cat improves and you save the owner $180 in testing. Assign this a net benefit of $600, accounting for treatment cost and the value of rapid symptom improvement. If your clinical impression is wrong, probability 40%, the cat doesn't respond to methimazole, you've wasted 3 weeks of inappropriate treatment and you now need to do the full workup anyway. Assign this a net loss of $300 for wasted treatment time, owner frustration, and delayed diagnosis. Expected value, 0.6 times 600 plus 0.4 times minus 300 equals 360 minus 120 equals $240. Option B, test first. If the test confirms hyperthyroidism, probability 60%, you treat appropriately. Net benefit is the $600 from correct treatment minus the $180 test cost equals $420. If the test confirms diabetes mellitus, probability 40%, you treat appropriately for diabetes, which the owner and cat value highly because diabetic management without an early diagnosis leads to significant suffering and crisis presentations. Net benefit, $530 value of appropriate diabetes mellitus treatment minus 180 for the test equals $350. Expected value, 0.6 times 420 plus 0.4 times 350 equals 252 plus 140 equals 392. Test first wins, expected value 392 versus 240. The tree makes explicit what intuition often misses. The cost of being wrong with empirical treatment is high enough, often enough, that testing first has greater expected value even after subtracting the test cost. Sensitivity analysis question: how high would the pretest probability for hyperthyroidism need to be before empirical treatment becomes the better option? This is the kind of analysis a decision tree enables. You can vary the probability and recalculate until the two options are equivalent, identifying the threshold at which the recommendation switches. Decisions involve programs rather than individual patients, vaccination campaigns, disease control programs, biosecurity investments, surveillance systems. The analytical framework shifts to program-level economic evaluation, cost-benefit analysis, and cost-effectiveness analysis. Cost-benefit analysis converts all inputs and outputs into monetary terms and calculates whether the program generates positive net value. Benefits might include reduced treatment costs, reduced mortality, valued economically as production losses prevented, reduced regulatory response costs, reduced public health costs if zoonotic disease is involved. Costs include vaccine purchase, administration, monitoring, and program management. The net benefit is benefits minus costs. The benefit-cost ratio is benefits divided by cost. A BCR above 1 means every dollar invested in the program generates more than a dollar in benefit. The program is economically justified. The challenge with CBA is assigning monetary values to outcomes that don't have natural price tags. How much is preventing one case of animal suffering worth? How much is a farm family's peace of mind during a disease-free year worth? These valuations are necessarily judgmental and often contested, which is why CBA results should always be accompanied by sensitivity analyses showing how the conclusion changes when these value assumptions change. Cost effectiveness analysis sidesteps this problem by expressing outcomes in natural health units rather than dollars. Instead of asking, is this program worth the money? CEA asks, what does it cost per unit of health outcome achieved? For animal health, relevant outcomes might be cases of disease prevented, animals saved, or production units preserved. For zoonotic diseases with human health implications, outcomes might include human cases prevented or quality-adjusted life years, QALYs, saved. The incremental cost effectiveness ratio, ICER, compares two programs. ICER equals the difference in cost divided by the difference in effect. If program A costs $50,000 more than program B, but prevents 100 additional cases, the ICER is $500 per case prevented. Whether that's acceptable depends on the decision maker's threshold. How much are they willing to pay per case prevented? Benefit and cost effectiveness analyses are powerful tools for comparing programs at the population level, but individual clinical and herd level decisions require a somewhat broader framework, one that explicitly accounts not just for costs and benefits, but also for feasibility and acceptability. This is what risk-benefit assessment provides. The four dimensions must all be addressed for a complete risk-benefit assessment. Consequences. What are the potential benefits and potential harms? This is where NNT and NNH from Talk 3.3 become the operative metrics. How many animals do you need to treat to benefit one? And how many before one is harmed? In a population medicine context, consequences also include the number of cases prevented, herd immunity achieved, or production losses avoided. Probabilities. How likely are the benefits and harms to actually occur? This is where your pretest probability, effectiveness estimates, and disease incidence rates provide the quantitative inputs. High consequence outcomes with low probability may be less important than moderate consequence outcomes with high probability, or vice versa, depending on the severity and reversibility of the potential harm. Feasibility. Can this intervention actually be implemented in your specific context? A vaccination protocol that requires weekly veterinary visits is not feasible for a small beef producer in a remote area. A biosecurity protocol requiring laboratory confirmation before treatment is not feasible in an acute outbreak. Interventions with poor feasibility have lower real-world effectiveness than their theoretical efficacy would suggest, connecting back to the efficacy-effectiveness gap from Talk 5.2 and 6.3. Acceptability. Will the affected parties accept the intervention? Client values, economic constraints, cultural factors, and individual risk tolerance all shape whether a theoretically optimal intervention will actually be implemented. An intervention that an owner won't accept or can't afford has zero real-world effectiveness, regardless of its theoretical merit. Risk-based prioritization applies these dimensions at the population or program level. Not all risks merit the same response intensity. Allocate the greatest resources to the highest impact opportunities, those where consequence severity, probability, and population size at risk combine to produce the largest expected burden. This is the foundation of rational resource allocation in veterinary public health. All of the analytical tools we've covered, decision trees, cost-benefit analysis, risk-benefit assessment, require assigning values to outcomes. But in clinical practice, values are not fixed, objective, or universal. They're personal, contextual, and often unstated, which is why eliciting them explicitly is one of the highest value clinical communication skills. Utility theory provides the formal framework for quantifying subjective preferences. A utility of 1 represents the most desirable possible outcome: full recovery, full function. A utility of 0 represents the least desirable outcome: death, or the worst possible state. Most real outcomes fall somewhere in between, and different people assign different utility values to the same outcome. The concept of declining marginal utility captures an important psychological reality. The value of each additional unit of benefit decreases as you already have more of it. Moving from a 0% survival probability to a 10% survival probability is enormously valuable. It's the difference between hope and despair. Moving from 80% to 90% survival probability is much less psychologically impactful, even though it's the same absolute improvement. This mathematical property of utility functions explains why people are risk averse. The pain of losing something is greater than the pleasure of gaining the equivalent amount. In clinical practice, you don't need to formally measure utility values, but you absolutely need to elicit and respect what your client values. The explicit question, what matters most to you and how we approach this? Or are you prioritizing survival at any cost, or quality of life and comfort? Fundamentally changes the decision conversation. A client who values quality of life above all may make a completely rational decision to forego aggressive treatment that a survival maximizing client would pursue. Neither is wrong. Your role as the clinician is to provide the best available evidence, clearly communicated, and then support the client in making a decision that aligns with their values. The declining marginal utility concept also has direct implications for how you frame treatment options. Presenting the expected value of a treatment in terms of survival probability is less informative than presenting it in terms that capture the client's specific value. This treatment gives your pet the best chance of being fully functional again, versus this treatment extends expected survival by 3 months, but with significant side effects and reduced quality of life during that time. Summary: decision trees structure choices by mapping decision nodes, chance nodes, and terminal outcomes with their probabilities and values. The fold-back method calculates expected value by working backward through the tree. Cost-benefit analysis converts everything to money and calculates net benefit or benefit-cost ratio. Cost-effectiveness analysis expresses outcomes in natural health units and calculates cost per outcome, without requiring monetary valuation of health. Risk-benefit assessment evaluates consequences, probabilities, feasibility, and acceptability simultaneously. Risk-based prioritization focuses limited resources where impact is greatest. Utility captures subjective preferences. Declining marginal utility explains risk aversion. And eliciting client values before presenting options is the foundational clinical communication skill that makes all of these analytical tools clinically relevant. In the final talk of this series, we bring everything together in the context of risk communication: how to translate epidemiological evidence, probabilities, and decision analyses into language that clients, producers, and policymakers can actually understand and use. Pause the video and try your hand at answering the questions. We'll then work through the answer together. Question 1. Decision tree and expected net benefit. Simplified structure. Program branch, annual cost is $8,000. Annual expected benefit, 40% reduction, times 22 $8,000 in prevented losses equals $8,800 prevented losses per year. Net annual benefit equals 8,800 minus 8,000 equals 800 per year. Over 3 years, $800 times 3 equals $2,400 net benefit. However, this simplified calculation assumes 100% effectiveness. A more realistic tree, the program achieves the 40% reduction, P equals 0.85, annual net equals $800, 3-year net equals $2,400. Program achieves less than a 40% reduction, e.g. 20% due to incomplete compliance, probability equals 0.15, annual benefit equals 4,400 minus 8,000 equals negative 3,600. 3-year net equals negative 10,800. Expected net benefit over 3 years equals 0.85 times 2,400 plus 0.15 times negative 10,800 equals 2,040 minus 1,620 equals 420. The expected net benefit is positive but modest, essentially break even. Question 2, benefit cost ratio. Total 3-year cost equals 8,000 times 3 equals 24,000. Total 3-year benefit equals 8,800 times 3 equals 26,400. BCR equals 26,400 divided by 24,000 equals 1.1. A BCR of 1.1 means for every dollar invested, $1.10 in production losses are prevented, marginally above 1, technically justified, but barely. Question 3, utility theory and the retiring producer. The producer is expressing a time horizon in utility problem, not a rational behavior. A Yoni's control program takes 5 to 10 years to meaningfully reduce herd seroprevalence. However, the herd sale value matters. A herd with documented declining MAP surveillance can command 200 to 400 per cow premium. For a 200 cow herd at 300 per cow premium, $60,000 increase in sale value against 24,000 program cost, a BCR of 2.5. Question 4, feasibility and acceptability. Feasibility, labor capacity for annual ELISA testing. Calf separation infrastructure. Slaughter market for seropositive cows. Record-keeping systems. Acceptability, producer's risk tolerance. Values around animal welfare. Relationship with premium markets. Family succession plans.